Welcome! It's my pleasure to host Ventinova's first webinar that we organized to share clinical experience and scientific data on FCV ventilation technology. My name is José van der Hoorn. I'm Ventinova Medical's clinical director. Welcome, Dr. Jeroen Meulemans from Leuven University in Belgium. Thank you for being able to share your clinical experience as a laryngeal surgeon. On working while Tritube and FCV ventilator Evone is being used. Your presentation shall take approximately 30 to 35 minutes, and after that we have some time for a Q&A session. So all the audience is invited to ask questions in the chat function, and then I can ask them afterwards to Dr. Meulemans. Dr. Meulemans, would you please be so kind to briefly introduce yourself first and then share your data? Well, the floor is yours.
Thanks. So I'm Jeroen Meulemans. I'm one of the head and neck surgeons and laryngologists who work in the University Hospital Leuven in Belgium. So I'm mainly involved in oncologic head and neck surgery and laryngeal surgery. So glottic stenosis, subglottic stenosis, and of course malign diseases. I will be giving this talk on behalf of my two fellow colleagues, Professor van der Poorten and Professor De Lage. So let's start with the talk.
Good afternoon, everybody. My talk will be about the Evone flow-controlled ventilation during endoscopic upper airway surgery. My name is Jeroen Meulemans. I am a head and neck oncologic surgeon and laryngologist working in the Department of Otorhinolaryngology and Head and Neck Surgery in the University Hospitals of Leuven. I will be giving this talk also on behalf of my dear colleagues Pierre De Lare and Vincent van der Poorten. First, I would like to point out that I do not have any potential conflicts of interest to declare. Unfortunately, I don't have any shares of the Ventinova company. So this will be the talk of this evening. I will first start with an introduction, highlighting the endoscopic upper airway surgery procedures and also the current ventilation possibilities. Then I'll talk about flow-controlled ventilation and in particular the Evone and Tritube system. I will talk a little bit about our University Hospital Leuven early experience with this system on which we have been publishing. And I will give you my opinion about current and future indications, advantages we will highlight, and of course also drawbacks. And I will finish with some cases and so let's start with the introduction. So first for you, as I know that many of the spectators will be anesthetists, I will need to admit that I will give this talk from a surgeon's point of view. I'm a surgeon, I'm not an anesthetist, and I will tell or talk about the advantages of this system as a surgeon. Of course, in airway surgery, anesthetists and surgeons do have some shared emotions. And when you will see here the wisdom of anesthesia, this is also the wisdom of airway surgery. We are having minutes of thrill and seconds of terror during airway surgery. Only the hours of boredom we do not share with anesthetists. So the first aim during endoscopic upper airway surgery is to secure the airway and provide a safe and stable ventilation. This could be quite challenging, for instance in a grade 3 subglottic stenosis like you can see here in the picture. It gets quite difficult when you need to intubate this patient with a normal endotracheal tube. Here you can see the grading system, the Cotton-Meyer grading system of subglottic stenoses, and grade 1 and 2 are quite easy to intubate, but grade 3 is quite more challenging. Grade 4 of course is impossible and will need tracheotomy, for instance. Another challenge is the posterior glottic stenosis, in which we will see that the arytenoids are in the adducted position and the vocal folds close to each other. Also in these cases, normal endotracheal intubation could be very difficult to near. The second aim is to provide an adequate workspace for the surgeon. For instance, when you can see here this large and bulky tumor of the vocal cord, then when we need to perform a transoral laser microsurgical procedure in order to remove the vocal cord, including the tumor, we as surgeons, we need a lot of space to do the job. So, which are the current ventilation possibilities nowadays? Of course, like all of you know, we have the conventional ventilation with an endotracheal tube. Now, the ventilation is, as usual, a volume-controlled ventilation, or VCV, and it uses a regular endotracheal tube, which diameter is too large for intubation in case of severe laryngotracheal stenosis. Also, it leads to an important reduction in surgical workspace, and for us it's very difficult to approach the posterior glottic region because the tube, of course, is resting at this posterior commissure in between the arytenoids. On the other hand, another option is the high-frequency jet ventilation. So this uses a high-frequency ventilator which insufflates small volumes of air at a supraphysiological rate. And it uses a non-cuffed small bore endotracheal tube with a diameter of approximately 4 millimeters. Of course, this tube is superior when it comes to intubation of narrowed airways, and it also improves greatly the surgical access, including the posterior glottic region. Now, of course, the jet ventilation is not ideal, and it has quite some drawbacks. So first, it can induce potential barotrauma due to the high pressure the air will build up through the narrow tube. Also, the jet ventilation relies on a passive backflow of the insufflated air. So we have active inflow and passive backflow, and this could be a problem in severe stenosis cases or bulky tumors, leading to air trapping and hyperinflation of the patient with hypercapnia, which will necessitate a ventilation pulse, which in its turn will lead to hypoxia, leading to necessity for reoxygenation with high oxygen levels, and this will of course also interrupt the carbon dioxide laser surgery because we need to work with a low oxygen rates in the airway, less than 30%. On the other hand, jet ventilation is also quite difficult in a lot of laryngeal cancer patients due to their poor pulmonary reserve. These are smokers, these have really heavy respiratory comorbidities, for instance emphysema, and jet ventilation can lead to quite some difficulties. Also, when using the jet ventilation, we can see the oscillation of the vocal folds due to this backflow, and this really hampers precise laryngeal surgery. Another possibility is what we call the supraglottic superimposed high-frequency jet ventilation. In this case, a sort of a jet laryngoscope is used, and the jet ventilation system is connected to the laryngoscope. So we can have a jet ventilation not at an infraglottic but at a supraglottic level. Now, there are some publications on this way of ventilation. For instance, a nice publication from a Dutch group, and they showed that in quite a big population of 224 cases, 12% of their patients ventilations had to be definitively or temporarily converted to normal endotracheal tube ventilation because of desaturation. And they also observed that the risk of conversion to endotracheal intubation was higher in patients with a history of pulmonary disease or elevated BMI. So this supraglottic superimposed high-frequency jet ventilation isn't the holy grail. Of course, there are some other extreme possibilities for ventilation. We can do a coniotomy or a tracheotomy, but luckily they are only reserved for the urgent setting and for the most severe cases. So let's talk now about the flow-controlled ventilation, the Evone and the Tritube system. So FCV, or flow-controlled ventilation, uses a negative pressure which is induced inside the ventilator during the expiratory phase, and this leads to a constant outward flow during the expiration. Here you can see in the curves the difference between a volume-controlled ventilation versus the flow-controlled ventilation, with in the flow-controlled ventilation a constant outward flow. Now, what's the basic principle behind this? It's based on the Bernoulli's principle, and just a quick rehearsal from secondary school. So the Bernoulli principle tells that when air flows through a tube which is narrowed, the velocity of the air will rise through the narrower part, and in the meantime the pressure will drop. So we are creating a negative pressure, and this is used in the Evone system. So during the inspiratory phase, air is insufflated into the lungs of the patient through the Evone system, and during the expiratory phase, the air is bypassed, is insufflated through a narrowing in the system, and this creates a negative pressure, and this negative pressure will suck the air out of the lungs of the patient. So we have an active inspiratory phase, and to the contrary, with the jet ventilation, we also have an active expiratory phase. So the Evone and Tritube systems are produced by the company Ventinova, based in Eindhoven, the Netherlands. The Evone system you can see here, it's an automatized flow-controlled ventilator, and it's used in combination with the Tritube, which is a very nice cuffed small bore tube with an outer diameter of 4.4 millimeter. It has 3 lumens, one for in and deflation of the cuff, one for airway pressure measurement, and one for ventilation. Here you can see the comparison between the small bore Tritube and the conventional tubes, which intermediate or large diameter. So I would like now to report on our early experience. So we were quite pioneers in using the Evone system. And we reported on our very early experience in the Frontiers in Surgery journal. Now, the setup of this study was a retrospective observational setting. It's a single center case series in a tertiary hospital. And the aim of this descriptive study was to assess the feasibility and the safety of the Evone ventilation during specifically endoscopic airway surgery. So we analyzed the first 15 consecutive patients. So this is really representing the beginning of the learning curve, and we started in November 2017. Concerning patients and methods, first I will need to point out, and this is quite important for when you would like to use the system, that we are using 1 hour before surgery the administration of 0.2 milligrams of glycopyrronium in order to reduce mucosal secretions before and during the intubation, and this to prevent the small bore tube to be blocked by the secretions. Then, of course, anesthesia was induced with propofol and remifentanil and a neuromuscular blockade with rocuronium. The Tritube was inserted with cuff inflation and start of ventilation at full neuromuscular. So we reported on 15 patients, all underwent a direct laryngoscopy, and the procedures we performed were endoscopic treatments of idiopathic subglottic stenosis using the carbon dioxide laser and balloon dilatation. We did balloon dilatation of a tracheal stenosis, also laser endoscopic treatment of posterior glottic stenosis. We performed transoral laser microsurgery or biopsy takings for laryngeal malignancies in 7 patients. and also some benign lesions in the posterior glottic or supraglottic location were resected using the Evone in 2 patients. So we could see that the Evone system provided a safe and stable ventilation in all cases with stable oxygen and carbon dioxide levels. The surgeon was provided with an adequate working space in all cases. There was no interruption of surgery necessary in none of the patients, and no complications, adverse events, or intraoperative difficulties were reported. So we were quite results. Now, which are the current and the future indications? So, and here I will talk a little bit about our experience in our center and our ID. So it's not evidence-based, but it can give a certain... So at this moment, we always use the Evone system for endoscopic surgery for the laryngotracheal stenosis, so for posterior glottic stenosis, for subglottic stenosis, and also for proximal tracheal stenosis, on the condition that the lumen of the trachea or subglottic or glottic region is more than 4 millimeters. Also, I love to use it during a direct laryngoscopy and biopsy takings when dealing with a large obstructing malignant tumor of the larynx and the hypopharynx, because in these cases I am a little bit afraid of a normal endotracheal tube creating quite some edema and maybe or potentially leading to postoperative need for a urgent tracheotomy. Same is true for the patients with a severe laryngeal edema following radiotherapy or chemo-rad, and who need to undergo a direct laryngoscopy, examination under general anesthesia, biopsy takings. Also in these patients, it's important to have a minimal invasive intubation with a minimal of induced tissue edema to prevent potential postoperative tracheotomy. Another indication is the laser treatment, so laser evaporation of recurrent respiratory papillomatosis with a posterior location. Because I used to use the jet ventilation, but this implies various problems. So we have the vocal fold oscillation, which hampers a precise evaporization. And also there is theoretical the HPV distribution throughout the tracheobronchial tree when using the jet ventilation, and exposure of papillomavirus to the... Now, another indication is the surgery on benign, premalign and malign lesions involving the posterior laryngeal compartment, so the arytenoids, including the vocal process, the posterior commissure, posterior third portion of the true vocal folds, the ventricles, and the false vocal folds. And especially when we are doing TLM or transoral laser microsurgery for T1, T2 laryngeal cancer involving the posterior laryngeal compartment. And also for bulky laryngeal squamous cell carcinoma, which will be resected with TLM, and in which cases a jet ventilation could be difficult due to the potential limitation of the back expiratory flow. Now, I would like to point out a very nice paper written by Giorgio Peretti and his team from Genova in Italy. He is the Pope of the transoral laser microsurgery, and he published a very nice paper in which he reported on the use of jet ventilation during TLM as opposed to the use of an endotracheal tube. And he concluded that the use of a jet ventilation during TLM allowed for easier and safer management of the patients with a T1, T2 squamous cell carcinoma of the posterior laryngeal compartment, with reduced rates of positive superficial and deep surgical margins. So the jet ventilation gave more walking space to the surgeon, and it was easier to control the margins, and this resulted in more negative margins, and so probably better oncologic outcome for the patients. You can see here, so in many cases, he started the procedure with a normal endotracheal tube, and when addressing the posterior part of the resection, he switched intraoperatively to the jet ventilation. So if TLM lasted or was expected to last for longer than 1 hour, the resection was started anteriorly with an endotracheal tube and later switching to the jet ventilator for resection of the posterior part. The reason for this was to reduce the risk of hypoxia, hypercarbia related to the prolonged use of the jet ventilator. Now, the authors did not report any complications of difficulties related to the use of the jet ventilator, but for sure, the switching from normal endotracheal tube to jet ventilator will lead to a prolonged operating time and also implies an additional risk to the patient, let's be honest. So I think that the Evone is ideal for this TLM of laryngeal tumors involving the posterior laryngeal compartment, because it combines the advantages of the jet ventilator with a small bore tube and also an easier to secure adequate posterior margin, with also the advantages provided by the endotracheal tube. This is the stable ventilation. Concerning future indications, it could be an idea to ventilate patients with the Evone system who are suffering from subglottic or tracheal stenosis and who are undergoing an open surgical procedure such as a cricotracheal resection or a segmental tracheal resection. So in this case, nowadays we are first intubating the patient or with a small endotracheal tube or using a laryngeal mask, then do the resection. During the resection we will use a Montadon tube in the tracheal stump, and then when finishing the anastomosis we will switch to the first ventilation modality. Now this could be easier by using the Evone system. By using the Evone ventilation, this could guarantee first a minimally traumatic intubation and safe and stable ventilation, while also leaving a sufficient workspace for the surgeon to perform the resection and the airway anastomosis. So let's talk a little bit about advantages. First, advantages which are related to the use of a small bore tube are, of course, the excellent accessibility and the visualization of the surgical site. Also, it's easier to intubate patients with severely narrowed airways, and also it will induce minimal edema and damage to the tissues, which potentially decrease the need for postoperative tracheotomy. Now, the use of a cuff tube also has some advantages, so there will be no exposure of the surgeon to aerosols, for instance papillomavirus, but also think about the COVID story, and this in contrast to the jet ventilator, in which the surgeon is exposed to a lot of aerosol production. There will also be no hindering oscillation of the vocal folds, making more precise laryngeal surgery possible. Advantages which are connected to the use of a flow-controlled ventilation system is the creation of an adequate expiration also in obstructed airways without risk for hyperinflation and barotrauma, like we can see in the jet ventilation. And also, thanks to the FCV, we will be able to provide an effective ventilation in patients with respiratory comorbidities. And when looking at the complete system, so the team of the Evone and the Tritube, we believe that it's time-saving when we compare it to the high-frequency jet ventilator, because there is no need to interrupt the surgery, raising the oxygen levels. Another potential advantage of the Evone and Tritube system is recently reported by Gauthier de Sutter from the UCL in Brussels, in which he used the Evone during tracheostomy. So he inserted the Tritube via or through the endotracheal tube and ventilated the patient with the Evone system during a tracheostomy. So the tracheostomy could be performed in a safe and easy way while the patient was ventilated with the Evone system, and the Tritube gave enough space to perform the tracheostomy in a safe way. And only when the cannula of the tracheostomy was in place and the cuff inflated, switch of the ventilation was performed from Evone system to cannula with removal of the Tritube. So this has potential advantages of an aerosol decrease during the tracheotomy, which is really an advantage in patients with COVID, for example, and also it decreases the apnea time. So let's focus now on potential drawbacks of the Evone system. So the use of the Evone system is no option when the airway diameter is less than 4 millimeters. In the case of these very severe laryngotracheal stenoses, another possible way for ventilation could be the superimposed jet ventilation, or in the very, very severe cases, a temporary tracheotomy. With the Evone system, we can only do adult cases. I do not have any experience with pediatric cases, and I don't think it's approved to use it with pediatric cases. Also, we see that the ventilator preparation takes some time, so the ventilator needs to be calibrated with using an artificial lung, and this takes 5 to 10 minutes, which is absolutely no issue during elective surgery, but it could be problematic in emergency situations. Sometimes we see blockage of the Tritube with secretions. That's why we are administering our patients glycopyrronium before induction. When we are dealing with a blocked Tritube, flushing of the Tritube with some physiological serum works out well. Finally, it also is necessary to state that the Tritube is not officially certified as a laser-safe tube, which could be a problem if local or national regulations necessitate formal laser-proof certification. However, we did not encounter any incidents, and of course standard safety measures need to be applied. For instance, the oxygen rate needs to be less than 30% during the use of the carbon dioxide laser, and we also always position a wet cottonoid on top of the cuff in order to prevent accidental laser-induced damage to the tube or to the cuff. Of course, there's not a single ventilation way which is absolutely perfect, and I think that I will need to wait for a very, very long time to meet my perfect partner. So let's now focus on some cases as examples. So the first patient is a female teacher of 37 years old who presented at my clinic with stridor and intolerance for physical activity. On spirometry, the peak flow was 52% of what was predicted for her age, and the CT scan showed the image of a subglottic stenosis. So a underlying autoimmune pathology was ruled out, and the diagnosis of a idiopathic subglottic stenosis, quite typical in young ladies, was made. So during anesthesia, we could see on an endoscopic view this grade 3 subglottic stenosis with a safe and good ventilation with the Evone system. Here you can see the Tritube going through the small hole in the subglottic region. And also this provides quite some good working space during the surgery. Here you can see how with the laser beam we are using the Superipposed system, and we are making or incising with the laser a Mercedes star radial incisions in the subglottic stenosis, and the use of the Tritube system makes sure that we have enough workspace to do this job. Next, I am quite used to remove the Evone system, to remove the Tritube and then perform 2 balloon dilatations during apnea. You can see here the result. So the balloon is inflated, left in place for 2 minutes and then deflated, all during apnea, with as a result a quite good to normal subglottic lumen. Postoperatively, this lady evolved to a normalized peak flow with a normal inspiratory and expiratory curve. So case 2 is a female sales manager, 45 years old, and she is known in my clinic with recurrent idiopathic subglottic stenosis. She underwent 2 prior endoscopic treatments with always recurrence of the subglottic stenosis, and we proposed to her a cricotracheal resection. However, she wants to postpone this as long as possible because of the voice concerns. We know with the cricotracheal resection the voice will undergo some changes, and she wanted to postpone this as long as possible. So, because of recurrent complaints of stridor and intolerance for physical activity, we performed a 3rd endoscopic surgery, and we could see, thanks to the Evone system and the Tritube insertion, that there was quite some posterior scarring at the subglottic region. So when we intubate someone with the Tritube, it's very easy to lift with a direct laryngoscope the Tritube up and place the Tritube in the anterior commissure, and then we have quite some good exposure of the posterior part of the cricoid and the subglottic region. So we incised with the laser the posterior scar, performed again a balloon dilatation, and also in this case you can see a very good subglottic lumen. Case 3 concerns a male of 83 years old who is known in my clinic with a recurrent respiratory papillomatosis of the glottic and supraglottic region induced by the more aggressive HPV type 11. So he presented with a very bulky recurrence in supraglottis and glottis going to the posterior commissure, and I love to use the microdebrider in these bulky cases. So first we need working space to make endoscopic assisted and microdebrider assisted removal possible, and on the other hand, as the lesions are going very far posteriorly, it's necessary to have a good visualization of the posterior part, and this could be achieved with the Tritube. So here you can see the microdebrider doing his job, and as a surgeon you have a wonderful working field and a wonderful exposure from up to the anterior commissure to the posterior glottic region. So there are 2 reasons why in cases like this I never liked using the high frequency jet ventilator. First, because the bulky papillomatosis will obstruct the passive backflow, you have a high chance for hyperinflate the patients. And second, using the jet ventilator will expose the surgeon to quite some aerosol production, and in case of recurrent respiratory papillomatosis, I really don't like. Case 4 is a man of 56 years old with a history of prolonged intubation after a fall with consequent craniocerebral trauma. Now, the patient presented in my clinic with stridor and intolerance for physical revalidation exercises, and I diagnosed him with a posterior glottic stenosis grade 4. So the arytenoids were in a continuously adducted position, and on CT scan we could see quite some scar tissue between the arytenoids. So bilateral arytenoid ankylosis and a peak flow of 40% of the predicted value. So peroperatively we performed a laser-assisted posterior chordotomy. Below in the image you can see the very small Tritube, and it's very apparent that with this system you have a perfect view on that posterior part of the. So I will finish with the fifth case. He was an 80-year-old smoker, presented with hoarseness, and on endoscopic examination, we did observe a T1 squamous cell carcinoma of the left vocal fold with posterior extension to the vocal process. So we scheduled him for a transoral laser microsurgery of that T1 squamous cell carcinoma. Here you can see the situation during the TLM. So first, the Evone ventilation allowed us to provide an optimal margin assessment. So we are using the narrow band imaging system from Olympus. And besides allowing for optimal margin assessment, it also provides for a maximal working space during the TLM. And make sure that we can provide a safe posterior margin. So in this case, we performed a carbon dioxide laser vestibulectomy and an ELS type 3 chordectomy. Here you can see the result with ideal posterior margin determination and safe margins at the posterior aspect as a result. These were the cases. I would just like to give one concluding remark. So at this moment, with the introduction of the Evone system, in my practice, high frequency jet ventilation isn't used anymore. But on the other hand, for me, the Evone and the Tritube are quite a winning team, so I really like to use it. I thank you very much for your attention, and I'm open for questions. Good afternoon, everybody.
Thank you.
My talk will be about...
Thank you very much for your elegant presentation. In the chat, I already saw that we have some questions, some burning questions for you. So I'll use the time asking these questions to you. The first one is on obstruction of a tritube. You mentioned that the use of glycopyrronium is used to prevent secretions blocking the tube, but it still happens sometimes, you say. You use saline. How often does it happen? And do you have other types or manners to prevent this?
Yeah, how often does it happen? When we take the precaution of using the glycopyrronium before induction, like 1 hour before induction, it's quite rare that it will still be happening. But in cases of patients with a severe subglottic stenosis, they quite often have some stasis of sputi, of secretions underneath the stenosis, and these are the patients who are at risk for having a blocked tube. And so in that case, we are keeping the flushing syringe quite close, and with flushing once, twice, sometimes 3 times, the problem will be solved. In our experience, and nowadays, because the publication is quite some time ago, representing the beginning of our learning curve, but now we have experience of more than 150 cases, and we never had to remove a tube because of problematic obstruction when you take these 2 precautions. So quite rare.
Okay. Please always keep the syringe available with the saline and use glycopyrronium. Any other compound you would then suggest, like atropine or something?
No, I can't say. We never tried it. I don't have any experience with it.
And you also mentioned you use Tritube, which is not laser resistant in laser surgery. It's considered off-label use, of course, for us. Then you reduce the FiO2. How long does it take before patients desaturate, if they desaturate?
Yeah, that's one of the very nice things about the Evone and the Tritube combination. When using the jet ventilation, we really had quite often that when we were ventilating with FiO2 of 30%, that the patients were desaturating after some minutes of walking in the larynx. With the Tritube and the Evone system, it's really uncommon. and we only see it in these patients who are really having the severe respiratory comorbidities. So the patient with the laryngeal cancer who have been smoking for 70 years and who has a very important COPD with emphysema, then it could be that we need some pause in the laser surgery, but it really happens uncommonly, and that's mainly due because of the very physiologic way of ventilating the patient. So it's flow-controlled ventilation, and that is for the patients quite better than the usual jet ventilation. I think it's important to have the message that the system of Tritube and Evone, it does have two big advantages. So you, of course, have the possibility to use the Tritube, which is very small diameter, which gives exposure to the surgeon. But on the other hand, you have the Evone FCV ventilation, which is more physiologic and which can keep also quite difficult patients with a lot of respiratory comorbidities through the whole surgery with low FiO2s. So it's really uncommon that we need to pause the ventilation, and it's one of our main, or in my opinion, or in the opinion of my team, one of the main advantages that we can gain time because we don't need to stop the surgery, raise FiO2 weight for the laser. It's we as surgeons, we don't are really patient. We want to continue.
Yes, so basically you can now schedule more patients in one day.
Yeah, it's really, for us, it's time saving.
Oh, that's good. Good to know. There's another question, since this sounds like a more specific way of ventilation, it's a novel method. How long did it take to train the staff? I know you're the laryngeal surgeon, so not the anesthetist, but could you slightly comment on that?
Yeah. Of course, we work in the airway surgery in close contact and cooperation with the anesthetists. I'm seeing now in my clinic that the knowledge is shared very easily. It looks to me, but of course, like you already said, it's second-hand information because I'm a surgeon, not an anesthetist. But it seems to me that for the anesthetist, the learning curve is quite steep, and we are already in the phase that our staff surgeons are learning it to the residents, and that I'm doing surgery. We are a university hospital, so we have quite some residents or anesthesiologists in training, and they are getting used to use the Evone system, and it goes quite well. So it seems to me that after like one day in the operating room under the strict supervision of the staff surgeon anesthetist, that the residents are using the system in a very appropriate way.
Okay, but do you think it's also of value for the non-academic hospitals? Because Leuven is, of course, a big academic hospital, very experienced. What's your opinion about that?
That's of course dependent on what you want to do in your hospital. In Belgium, we have also quite some big secondary care hospitals, but also doing some laryngeal surgery. And I think if you want to proliferate as a center who is dealing with laryngologic surgery, so it can be vocal cord surgery, benign vocal cord surgery, but also lasers of smaller malign lesions, which is possible in Belgium, not in the Netherlands, because in Belgium there's no centralization of oncology care. But if you want, or you have the idea to get first well-renowned laryngological center, it could be, it is for sure an added value. Of course, not every center will need it, but it's good to keep at hand when you just want to do laryngological surgery, even when it's only benign surgery. Yeah. Okay. So there's a possibility for that. Yeah.
And is the system only used by your department in the hospital, or are there also other departments that use the system?
At this moment, we are, of course, we were the ones who started it together in a close cooperation with our anesthetists. But now, since quite recent times, it's also used by the anesthetists, of course, but during transplant surgery, so lung transplant surgery, we have some very brilliant anesthesiologists, professor of anesthesiology, who is very intrigued by all the possibilities of the Evone system during these thoracic surgeries. So
Okay,
quite shortly is using that.
And that also includes the one lung ventilation surgery?
Yeah.
Okay.
He has some beginning experience with it. And I'm sure that he will just broaden his experience, and I'm quite thrilled to see where it will end.
I know Professor Nijink. I think he will expand his.
Yeah, maybe he's listening. So Arne.
Next question is: Tritube is not laser safe. How to overcome this problem?
First, be careful. That's, of course, standard precaution, but the most important one. Second, I always ask the anesthesiologist to put the tube quite deep in, so at least 2 centimeters underneath the vocal cords, or 2 centimeters underneath the subglottic stenosis when we are dealing with subglottic stenosis surgery. So the cuff needs to be deep enough. And then I am very used, always, also when I'm using a normal conventional endotracheal tube, to put a very drenched wet cottonoid on top of the cuff. It's a cottonoid with a string on it, so the string gets out of the laryngoscope and is fixed to the laryngoscope, so I can't lose it inside of the trachea and the lung. And I very nicely put it under the vocal cords, or under the surgical area, but on top of the on the tube. And when we are lasering, and if it happens that the laser beam is shooting along the tissue, it will be absorbed by the wet cottonoid, and it won't damage the tube or the cuff. I once shot the cuff into pieces, but it doesn't mean that a big problem, so you can easily re-intubate even through the laryngoscope.
Okay, that's good to know, the troubleshooting. Another question, do Tritube and Evone reduce the procedure time as compared to high-frequency jet ventilation? I think you slightly touched upon that.
Mm-hmm.
So does it reduce the time you calculate?
Yeah, of course, it's not big science. It's we didn't do a randomized controlled trial where we compared the standard ventilation or the jet ventilation together and compared it with the Evone ventilation. So it's really more our opinion based. But as I told in the beginning, I'm talking for an entire team, and we are quite uniform in our idea that we are gaining time by using the Evone system. And that's because of the fact that we don't need to interrupt the laser surgery. But also, apart from gaining time, we are having less frustration during the operation, which is also quite important during our everyday walking life. But yeah, so for us, it's really gaining time, but I can't give you hard data on that because we never did a randomized controlled trial and compared them directly.
But for your, it also reduces stress and frustration.
Yeah, so for sure. My life is has been becoming a lot easier now. Also with the subglottic stenoses, in which in former times the jet ventilator would go into alarm because of the hyperinflation problem. Then we needed to hurry up, open the subglottic stenosis more, so we could give the passive backflow some space. But these are bygone times.
Oh, that's nice. Then I have another question. What's your idea about the nasal intubation of Tritube? Do you have experience with that? Is it applicable?
I heard that it's possible that some colleagues do it, but we don't have any experience with the nasal intubation. As a laryngologic surgery, I don't see the added value of nasal intubation. I just never came in front of the situation that I would have needed the nasal intubation. But for sure, it could be. I think it must be possible. It's a very flexible tube. It could get through the nostril, through the nose, whatever.
And another one, as the tube is so small, I think, can it be used to for single lung ventilation?
Yeah, I already touched on that. I've seen some communications from a Dutch group who are using it for single lung ventilation, but then they are making some adaptations on the cuff. We are more having, I spoke to Arne Nering today, and we are not having experience with the combination with the Tritube single lung ventilation, but we have experience with the FCV system, so the Evone system, and connected with a special adapter to a conventional tube, and really with the idea to have all the advantages of the more physiologic flow-controlled ventilation in these difficult patients. But single lung ventilation with the Tritube, there's no real experience
no, and I
in our center. But,
no, and I think
because
indeed
also the cuff is quite too big for single lung at this moment. So. Yeah, but of course, technically, it shouldn't be any problem.
Okay, well, I think you're exactly right on that. Well, I think these were the questions I would like to ask you. Thank you so much for being available at this time and for your elegant presentation, for sharing your clinical experience with us, and we highly appreciate that.
Thank you. It was a pleasure.
I thank the audience for watching and for asking these questions. In order to improve our webinars, we have a small poll with 3 questions, and we would be very happy if you could help us improving this webinar by just answering these 3 questions that which will appear on the screen. So thank you very much for attending this webinar. This one will be available soon on our website and on YouTube. A next webinar is scheduled for next year, February 17th. Then Dr. Nabil Shalik from Hamad Medical Corporation in Qatar, Doha, will share his experience in post-COVID-19 patients with severe tracheal stenosis. So on behalf of Ventinova, I wish you all a very pleasant holiday season. Stay healthy and take care. Bye. Thank you.
Ciao.
Ciao.